Thank you very much. So resistant keratitis is a big topic, especially if you add fungal and acanthamaeba to it. So I will concentrate on acanthamaeba and fungal keratitis. So what makes keratitis resistance? There are challenges in diagnosis and mixed infections. There are problems with resistance rates that are emerging. There are problems of our new surgical planes which we are creating with our own surgeries, such as LASIK and lamellar keratoplasties, and promising but not highly specific therapeutic modalities that we have on the market. So acanthamaeba keratitis can come very subtle with very little epitheliopathy, with subepithelial infiltrates or pseudodendrites, and as Professor Dua has showed you these pictures, these often are misdiagnosed as viral keratitis. So I always tend to tell my juniors in eye casualty that if it's a contact lens wearer, don't jump into viral keratitis. It's unlikely to be a viral keratitis. And if they've had steroids, they may end up presenting with a geographical ulcer. So perineuritis is pathognomonic for acanthamaeba. However, you're not going to get perineuritis on week 1. This is a sign which you will see on week 3 or 4. And if you see it, it's pathognomonic because the acanthamaeba cysts are usually clumped around the nerves, and as you will see, and here again much more evidence, and you can see this in 60% of cases about 3-4 weeks down from infection. Anterior uveitis can be an early presentation, and that's often missed as viral keratitis. But again, if it's a patient who's a contact lens wearer, be wary that it can be acanthamaeba. Limbitis can happen with acanthamaeba and herpes, and you can see limbitis very well if you put fluorescein and look with a blue filter. You will see the thickened limbus, as you can see here, and that can be an early or a late sign with both diseases. Then later on, you can get a single or double ring abscesses, ulceration, you get scleritis, cataract, and glaucoma, usually as complication of treatment, and even iris atrophy. So if you see multifocality with prolonged infection, which can actually mimic fungal in a contact lens wearer, you think could be acanthamaeba. Confocal microscopy, you will have a whole talk on this tomorrow by Farida Zawawi, our PhD student who had oral thesis, and will give us a lot of insight on how confocal can help with infectious keratitis. With that, you can see bright cysts, double wall cysts, and usually they are in clumps and deeper in the stroma. With that, you can diagnose acanthamaeba keratitis, but not superficial. If you see 1 or 2 cysts, that won't be diagnostic. So very, very subtle signs like this can have extensive IVCM images. So that's why this modality can be very, very helpful diagnosing acanthamaeba keratitis. Again, you can take a sample. You make an ulcer and take an epithelial biopsy and send it for staining and culture of non-mutant E. coli agar, because the E. coli will eat up the acanthamaeba. The trophozoites will eat up the E. coli, and then that will show. PCR is very useful and gives us very good results when other modalities fail, and then corneal biopsy if everything else fails. How do we treat acanthamaeba? We have epithelia for epithelial and stromal disease. We use PHMB 0.02% or chlorhexidine. They come from the same group, either or, and sometimes we use them synergistically. And one of the aromatic pyrimidines, such as pyrimidine or bromelain. But remember, the bromelain is quite epithelial toxic, and not every patient will tolerate. Then you can sometimes have an additional voriconazole or miconazole, and we find voriconazole quite useful as an additive when the other two not enough. Then there is always addition between chlorhexidine and PHMB, but remember, all of these are quite toxic, and synergistic effect sometimes between both. There is a new study by John Dodd and colleagues done on Offender where PHMB is used in a higher concentration as a single modality, 0.08, and showing no inferiority to the combined treatment. That allows you to give the patient only 1 drop rather than 2 drops, and it shows quite good results, maybe 86% recovery within a year. Now, if it extends to the sclera or you get uveitis, then only then you can use steroids. But remember, you have to always stop the steroids before you stop your anti-acanthamaeba. You can also use immune suppression such as cyclosporin or tacrolimus. You have to continue your treatment on very, very slow reduction on the number of treatment, and you can use non-steroidal anti-inflammatory drugs. Again, steroids only if you see signs of improvement, and you have to stop it before you stop the anti-inflammatory. Not before 4 months that you'll be able to stop if you catch it early. But I've had patients who have been on treatment for 2 to 3 years. So if it is not responsive to PHMB, sometimes it can respond to chlorhexidine. And remember the pressure, you can sometimes get very high pressure with acanthamaeba, and drug toxicity, if you see redness inferior, much more than superior, and you see areas of conjunctival staining, then you know that you're getting drug toxicity. You have to either stop your treatment for a while or reduce it. There are other surgical treatments such as debridement, penetrating or lamellar grafts. Biological thinking still in acanthamaeba cases is controversial. I'm just going to show you one of our very severe cases. This was a culture positive case, came in August 19, came with some epitheliopathy. We were admitted her, started her on treatment, then she went outside and stopped the treatment. She came back with large limbus trophic ulcer. Then we treated her again, had to put an amniotic membrane, the ulcer became smaller. Again, here it brings us to middle of 2020. And then we had to do a ulceroscopy, and then finally the ulcer healed. And from the toxicity of the treatment, she developed sudden onset of cataract, where we had to do a triple procedure. Then she had aqueous misdirection. You can see here there is no anterior chamber at all. Then the glaucoma people came in and put a tube, then the tube got infected. Finally, she had a clear graft. So that can just show you how long the journey of acanthamaeba patients can be. And these patients, you tell them, if you have a problem, just turn up, because they can't really rely on appointments in managing these patients. Now, going to fungal keratitis, now we know that 50% of culture positive IT in developing countries like Egypt will have fungal keratitis. Very important, the history of vegetable trauma, contact lens, patient is immunocompromised, hot climate, slowly lingering infection which is not responding to your initial antibiotic treatment, and that is all signs that you might have an additional fungal infection. Look at personal factors. I've had 2 patients which were visited for a long time. One had a fungal infection, one had a dog with fungal infection. So this can be actually the source of infection. And we get the feathery edge, the inverted hypopion, the plaque. These are all signs of fungal keratitis, OCT, and Shadia will speak to us about OCT. In infectious keratitis can also show you the amount of plaque on the back of the cornea and the response to treatment. And you can get that leathery shield which we have to debride so that the infection settles. You can get scleral and intraocular spreads, and if you get that, then you have to really do a very heavy systemic treatment. Remember the intraocular pressure and the corneal sensation, very important parts of the examination of your cases of resistant keratitis. And you take smears, so you might work closely with your microbiologist, because they can tell you in half an hour of potassium hydroxide wet smear if there is a fungal infection, for example, or not. Or you also culture. And these are all very, very helpful to help you, but the culture takes a longer time to give you results. And you get PCR also, which can also show you whether there is a bacteria or fungal. And if nothing is working, stop 24 to 48 hours and take a corneal biopsy, a teeth biopsy, which can show you exactly what is happening with the irritation. Again, the IVCM, Farida will talk to us again tomorrow, will show us the fungal hyphae, especially with aspergillus. These are not fungal hyphae, so you will have to be careful with interpreting the IVCM images. These are just created keratocytes which can look like a fungal hyphae. And again, if you see in your OCT that the separation of tooth layer, this type 1 detachment, this is quite common with very deep bacterial infection or fungal infection. And the treatment of fungal keratitis keratitis is usually amphotericin before candida or natamycin. Natamycin works very well for superficial fungi, but can cause a lot of toxicity. Azoles, voriconazole is broad spectrum, we use it quite often. And then there's itraconazole and other azoles, and echinocardias such as capsule, I personally don't have an experience with that. Then the mycotic ulcer treatment trial said that adjuvant oral voriconazole 400 twice a day, then 200 milligram twice a day for 20 days did not show any difference in the healing or best corrected visual acuity. But the voriconazole also is known to be quite toxic to the liver. So if you're giving voriconazole systemically, be careful, do liver function regularly. And then the debridement, if you see that leathery sheet, you really need to go and debride this to allow the antifungal to penetrate the cornea, to have a good penetration of the cornea. PaxCXL, we personally have good results with PaxCXL for superficial fungal infection, but not antifungal infection. And reports from India have showed that you can get complication if you cross-link patients with deep fungal infections. These are some of our patients in Rio, which were done here, where we did the initial study of PaxCXL in advanced keratitis, where actually it did show quite a lot of improvement, especially in mixed infections. One last modality which I would like to tell you about, which is the intrastromal injection, which is very good, of voriconazole 50 microgram of 0.1 ml, and that gives us very good results, especially if the patient has toxicity or the patient is not responding enough to treatment. This is one of very, very resistant cases. This is at admission. He had given amikacin as well as voriconazole, and then he got better, then he got worse, and so on, until he had a lot of toxicity. And then we started injecting him with voriconazole twice a week initially, and then eventually, once we stopped the injection, then he flared up again. So we carried on with the injection until he finally, we tried to add natamycin. He got a lot of toxicity from natamycin until he finally had 80 injections, both over the course of a year, and finally Professor Zuhar had done a therapeutic graft, and the patient had very good vision after. So you can just carry on with it. The injection will actually give good results, less toxicity when other modalities don't work. So this is the vision pre and post. Now, remember the interface infections. So this is a case of Professor Mustafa Salah, one of the post-LASIK infections where the patient got much worse, and eventually had to amputate the flap and do cross-linking, and we grew a very bad yeast infection. And then the patient finally got better after antifungal drops plus cross-linking. So because we're creating all these new planes, we can get any more resistant infections. Another patient of mine which had interface infection after dull perforation and gluing, 10 interstromal injections, and finally settled. This is again a TSEC patient from the wound, developed hypopia, and you can see these the lines which told us actually it's fungal infection, and were very apparent on IVCM, and with antifungals he responded well. If you're doing an excisional keratoplasty, try and get 2 millimeters of clearance. You might need to remove the iris and lens. Do not forget your peripheral iridotomy. And then also you can sometimes need to give voriconazole injection interstromal, and make sure you do interrupted sutures, because you might need to remove them early. So the take-home messages, you need thorough history, including personal history, high index of suspicion of acanthamaeba, especially if the patient is a contact lens wearer, but you can still get acanthamaeba without a contact lens wearer. Clean disproportion to the side, but not necessarily, and not in every case. It's commonly misdiagnosed as symplectic or arteritis. Radiant peritonitis is pathognomonic, but it's not an early sign. If the ulcer stops improving or getting worse, think of another bug. Treat early, avoid steroids and contact lens wearer, investigate, stop all treatment for 24 to 48 hours, culture, PCR, or if you have an IVCM, that's very, very useful modality. And do not stop treatment early. Use an armamentarium of treatment, and avoid therapeutic graft unless really you have a perforation or an absolute uncontrolled infection. Thank you.